1 minute. There we go. Yep. Can you switch off these lights? And I'll reduce my volume. Make it mute. So they are muted. Hello? Yes. Now we can dim off these lights. To wake you from your post lunch slumber, I am going to present something very, very different, probably a new topic for you. Physiological pain portals and sodium channel blocks. That's me, Dr. Prakash, I now practice in a place called Palakkad in South India. Now, what are the pain portals? The exact spot where the cocktail is to be injected is called a pain portal. The upper limb portals, it's not coming. Either a cloud recording is, you did something in the cloud and, yes, now it's okay. The upper limb portals are called alpha portals. Lower limb portals are called the beta portals. Trunk portals are called tau portals. And head and neck portals are called the kappa portals. What is the composition of the cocktail? Now, there is nothing which will stop you in using any of these because these are internationally accepted drugs. We use 1.5 ml of 2% lidocaine, 30 micrograms of clonidine, 10 milligrams of Kinocort or dipomidorol, 7 milliliters of water for injection. That makes a 10 ml volume of what we call a pentadiluted lidocaine. The final xylocaine is about 0.3 to 0.4% concentration, which is the essential ingredient. And for fracture and acute trauma, we eliminate the steroids and we just have this composition 1.5 ml of xylocaine, 7.5 ml of water for injection, and 30 milligrams of clonidine. Now, clonidine is not available in certain countries. So, what is used is 5 micrograms of dexmedetomidine. Pain portals have become very, very popular nationally and internationally. And the book is now on its 3rd edition. And this is the latest edition of the book, which is a medical bestseller in my country. I'm showing you certain videos of what these portals can actually do. Meaning, the camera has to be turned a little up. This is a lady with spondylolisthesis. And this case was sent to me from South America. You can see how much pain she is in, staggering to walk, straight leg raise, very, very restricted. And she was in agony. She was actually brought in a wheelchair. Now, this is immediately after the blocks. She is raising a thumbs up, saying that yes, she's doing well. And then you can see how she is getting up. She started to walk. She's gaining confidence. The lady who had 2 people to support her, to even hobble for a few steps, has now become independent. And the smile on her face widens and widens. And there she is picking up speed. And this daughter and son-in-law are extremely happy. And there she is dancing. Now, let us look at periarthritis shoulder. Let's start with this. Now, unless I turn the volume up, the audio won't be visible to the people. Can you hear the voice? No, pause it. No, what do you want? Oh. Hmm? What?
بس لندگا دغروغ لازم شتكا دغروغ لازم شتكا زبغروغ لازم دغيخان تكنيزة تكم دي بسم الله زبر ده دير خلاص شتكا زبر دبل شتكا كم نيجي ما أصلا ما خليه وزير كذا كم نيجي ما أصلا ما أردو ولا شيء أشكي تكليف شيء
No, he's thanking Dr. Prakash. So it's okay. So we have this one. Wait. So we'll forward this a little. He has got a pain, is not able to raise it. And immediately after the injection, there he's raising it. And there you can see how high he goes. This one is very interesting. There's some lag. There we go. See, this person was my butcher. And he had come to my house on a Sunday morning to take a loan of 5,000 rupees because his neurosurgeon advised him an MRI scan. He had an acute prolapse disc and he needed two people to support him. I told him, no, we've got Xylocan at home. I'll give you blocks. So these are beta 1, 2, 3, 4, 5. I'll tell you what these blocks are. And subsequently, you can see immediately after block. And that's him the same evening when he came to deliver me the meat. And he's sitting, getting up. So he didn't need an MRI, he didn't need a surgery. That's a case of fulminant herpes. This is Dr. Divakar's case. And you can see the first, second, and 3, just with tau blocks on 3rd day, the herpetic lesions are healed. So initially described for disc and neurological issues, these portal blocks are turning out to be increasingly useful in trauma and may soon become game changers in many situations. This is again from Colombia or some South American country. There was a professional jockey who was riding her horse. This is a videograph of her falling down. She landed on her shoulder and had a fracture of the lateral end of her clavicle. On the other side is the spot of the injection which the doctor has given her. And that is a video. Wait a minute. And that is a video sent to me by the patient. Immediately, 20 minutes after the injection, And this is exactly an hour and a half after the fall with the fracture, because this highly motivated patient wanted to take part in the race the next day. She did participate and she got a silver medal and sent me a special thank you note on the next day. This is common story. We all know trochanteric fractures. They are treated DHS, PFN, whatever, and less than 40% are alive to see their next birthday. Now, for fractures of trochanter can be displaced or undisplaced. And this is the blocks have been able to manage these fractures which are undisplaced in a dramatic manner. You can see this is a fracture that happened to my relative during the COVID times. And he was in Chennai, I was in Palakkad. He just sent my nurse and asked him to go to my friend's hospital. I asked my nurse to give a block. The beta 6 is given 1 finger breadth lateral to the femoral neurovascular bundle in the inguinal crease. And immediately after the injection, the patient walked. This hospital belonged to my orthopedic surgeon friend. He had already made all arrangements for surgery on the next day. But the patient walked home. One single injection is effective for a period of 5 to 7 days. And all I had to do was to ask my nurse to go to the patient's house and inject him every Sunday. And that is a patient at the end of 2 weeks at home, no surgery, and he's pretty comfortable going to the toilet using a Western toilet, fully weight bearing. And in as little as 45 days, his fracture united. With any fixation, it takes a minimum of 3 months along, and that's a fracture in 45th day. So portals are doing remarkably well. I think there's some time lag in the Zoom, and what I'm seeing on the screen is not reflected there. So there is one final X-ray. That's it. In 45 days, the fracture has united. Many examples. Day 1, day 30, day 80. Day 1, day 91. That is the spot of beta 6 portal where you give the injection. And that's another fracture which has united without surgery. Another one in 100 days. This one had a shortening of about an inch, but had taken a written consent. And that's him in about 90th day, full function, no limp, small shoe raise. Another one united. In the year 2024, to talk of treating trochanteric fractures non-operatively, orthopedic surgeons will have a heart attack. But this actually, we have crossed 800 to 900 cases, and I could get this published in the very prestigious Hip International, one of the most prestigious hip journals in the world. So I'll quickly run through the various portals, followed by specific indications. Alpha 1 is given in the first web space, given between the interossei and given at the intermuscular, subcutaneous to intermuscular level. That's the spot of A1. That's one of the most useful portals. And we owe it to Dr. Arvind Divakar, who will be speaking after me, for inventing this portal. An interesting fact that during the COVID era, me and Dr. Divakar used to discuss on phone, and using an insulin syringe, we might have injected about 200 spots in our bodies each. Know which injection works where. This is called Divakar portal. 2015, he has actually announced it in Facebook. Legal or official publications came much later. And this is useful for numerous conditions of wrist, elbow, and shoulder. So this is a huge list of indications where alpha 1 block works. So many conditions. No, you don't need to worry or take photographs because I'm going to send a PDF file of this talk to the group so that you get the entire gist and contents to read at home on your big screen. So in almost all these conditions, alpha 1 can be used. Alpha has got three subportals, alpha 1A, B, and C. And these are the other web spaces or interdigital areas. These interdigital areas, first and second, second and third, and one time lag here, time lag. So here we go. And the indications are these. Collie, Smith, carpal tunnel syndrome, metacarpal fractures, carpal fractures. These are the portals, alpha 1A, 1B, and 1C. Very short example. Wait a minute. I think it's a fracture reduction, so there's not very relevant in the slide. That's where the injection was given and how the fracture is, a hematoma block is given, and the patient is very pain-free, and we are putting a cast. Net is rather slow. What I see here, I'm not seeing there. And that's a reduction. And we have just introduced few more portals. These are the hypothenar and mid palm portals. These are adjuvant portals to the alpha 1 portal. Really helpful in a wide range of conditions. This is a hypothenar eminence portal, which is a mirror portal of alpha 1, which is called alpha 2C, which is very useful for humerus fractures and rotator cuff injuries. This is again a very, very important portal. This is given underneath the deep fascia in the carpal tunnel. It's a very important portal. And since we have discovered this portal, we have forgotten about RSD and pseudex atrophy. It's an adjuvant portal for a large number of conditions. But for CRPS and pseudex, repeated every 7 days, along with what we call low-dose Mukherjee regime, about which Dr. Mukherjee will be speaking after me, has eradicated the problem of wrist stiffness, osteoporosis, pseudex dystrophy, and I haven't seen one in the last 5-10 years. Alpha 3 and alpha 4 are medial and lateral epicondylar portals. And these are adjuvant portals for tennis elbow, golfer's elbow, and the like. Alpha 5 is given in the insertion of deltoid muscle. And this is again an adjuvant to alpha 1 portal and also very useful in periarthritis and frozen shoulders. Alpha 6 is at the inferior attachment to the scalenus muscle. Alpha 7 is the tip of acromion. And these portals have a lot of indications when you don't want to operate on a fracture. Actually, 80% of fractures don't need surgery. If you can see this patient, there he goes. And that's a 3-week X-ray because you've seen the previous X-ray. And now you are seeing the 3-week X-ray. There he is in 3 weeks. No plate, no fill-offs, nothing. Just block and started him on his work. Asked him to drive his bike home back without a sling or a plaster or anything. This would have undergone a Philos plate in any developed country. And you can see the range of his movements. This is an interesting one. You can see the old man on the right side. And you can see his hand. It's a Parkinson's, and you can see the tremors in his hand. He was not able to sign, and he was not able to get his pension check. And you can see the injection being given in alpha 7 spot. And you can see the hand shaking, shaking, shaking. The video is little slow on Zoom, so you're not able to see the very fine tremors he's having. And within 5 minutes, that's alpha 5 block. And you can see he will raise his hand. There he is. And the tremors have gone. So all we need to do, Parkinson's tremors, once in 15 days, give an injection, his tremors are gone. These are alpha 8 and 9 portals, anterior and posterior axillary folds. Again, extremely important of fine tremors, ghost tremors, functional tremors, and the like. You can see this lady on the right, how she is twitching, quivering. And on the opposite side, you can see her, how stable and steady she is. She was like suffering from intention tremor for such a long time. And there on the opposite side, you can see that's a video as well. Just she's holding it still and giving a smile. You can see another one. This is intention tremor. This woman will get tremors whenever she held any object in her hand. The hand is free, she won't get tremors. And then after that is the post injection. You can see she's holding something. The hand is steady, and she's holding something else on the other hand. Both hands are steady. She was struggling with tremors for 4 years, and now she's totally tremor free. Lower limb portals, the beta portals. This is a very important portal at the sinus tarsi level, where callus, calcaneum, navicular, and cuboid approximate each other. This was first described by Dr. Gore, a spine surgeon from Pune, India, and was called the Gore portal. And he described it as a diagnostic sign as to whether surgery will work or not. And we found out that this will avoid the need for surgery altogether. Backaches, MRI prone slip disc, and in conditions where endoscopic or open surgery is advised, beta portals are absolutely wonderful. Since we learned these portals, around 100 endoscopic spine surgeons have done our course, and their surgery rates have come down by 85%. This adjoint portal beta 2A, that's excellent for osteoporotic fractures of the vertebrae. Wedge compression fractures, beta 2A is like magic. And these are adjoint portals beta 1A, B, C, and D. We can just see an example. This is a patient, MRI prone slip disc, L51. That's one side, and you can see the agonizing expression on his face when he's trying to raise it. And that's the spot where it hurts him. And there he is, immediately after the injection in 20 minutes. Look at the smile on his face. That's the pre. You can look at his face, how agonizing it is, and that's him immediately after, 20 minutes later. Another one, this young girl. 20 minutes. And you can see her pre-injection straight leg raise. She's complaining of very severe pain in the sciatic region. And her straight leg raise is like 15 degrees. Here again, an MRI showed a very, very massive disc. And she was in trouble for about 2 years. And again, this patient received beta 1, beta 2, and beta 3 blocks. That's a normal leg. And she has also a contralateral pain, which restricts the raise of the normal leg also. This was what the endoscopic surgeons call as a laddu, a big prolapse disc, which they'll pluck it out with ease. And she's explaining her history now. I'm extremely sorry because we are doing it on Zoom. There's a great time lag because of the very slow internet speed. And so you're not seeing the videos clearly. You can see this, how high she's going, and you can look at her face. Beta 4 is above the head of fibula. Beta 5 is mid calf. Beta 4 and 5 are very good for osteoarthritis knees. grade 2, 3, they make the patient more pain-free. And grade 4 and 5, where TKR is advised, the patient's knee replacement can be pushed back considerably for a very long time. And I think we can delay TKR by 10 years by blocks. Now, here's a patient. You can see all three stages. That's how spastic his back is. That's him walking back after the injection. And that's last one is him coming back the next day or third day for follow. You can see how dramatic they work. Beta 5A is a shin portal, adjuvant to the arthritic portals. And shin portal is a primary portal for ankle fractures. 455A is tried in tibial fractures for casting. Beta 6, of course, I've told you before, ideal for trochanteric fractures. So I'll skip this video and show you an example. That's beta 6. Beta 7 is the mid-aligned crest and is a useful adjuvant for beta 6 and tau 4 for backaches. Beta 8 is the mid-thigh transquadriceps portal. We hit the femur, extract, inject. Very good for phantom limbs, post-amputees, patients who had major psychological trouble due to amputations, one injection and cures them. Beta 9 is mid-patellar, hit the patella and withdraw. The extra portal is beta 1, 2, and 3 for backaches and sciatica. Next comes tau trunk portals. There are 8 portals with very wide range of applications. Tau 1 is mid-sternal, tau 2 is mid-axillary, 3 and 4 are supra and umbilical, the sacroiliac portal, transverse process, inferior scapular, superior scapular, and ASIS. These could be called revolutionary portals because they are very useful in wide variety of cases, from COVID pneumonia, chronic obstructive pulmonary disease, abdominal colics, coronary diarrhea, compression fractures of spine, rib fractures, herpes zoster, assisted physio and chest infection, back pain without radiation, spondylolisthesis, and failed back syndromes. So that is the mid-sternal. Next is, so this is actually very useful in both chest infections and rib fractures. Status asthmaticus, ankylosing spondylosis, where chest expansion is not good. And we have seen this improving the oxygen saturation from 75, 74 to 98 within 20 minutes. This is extremely useful for large number of chest-related uses. Tau 2 is a mid-axillary line portal, excellent for any fracture rib. The fracture rib may be at any level. You would just inject mid-axillary line at 4th or 5th rib. Don't go into the pleura, hit the rib and inject there. And big lag, yes. So fracture ribs, even in stove-in chest and paradoxical respiration, this portal works wonders. And again, for all herpetic neuralgias, fulminant herpes, you just give a portal block, single block, and within 24 to 48 hours, the lesion start drying and 72 hours it dries off. The pain relief is dramatic. This is an example I showed you before. You can see how fulminant the herpes is on the left side and how it's beautifully dried up on the right side. This is called a surgeon's portal. It is just above the umbilicus, below the umbilicus, just subcutaneous, and it's useful in a wide variety of cases. Actually, in terminal malignancies, uterine cancers who have been inoperable, patient is on opiates, just these blocks will make the patients terminal and very, very pain-free. It's very useful in pediatric gastroenteritis, children crying due to abdominal pains, constipation, systemic viral illness, mesenteric lymphangitis, infantile colic, viral gastroenteritis, uterine colics, and gastritis in adults will disappear with this. Pain with PCOD, polycystic ovarian disorders, menstrual cramps. Then insulin syringe, you just inject 1 cc each above and below the umbilicus, and the lady's menstrual cramps goes away like magic. And for terminal palliative management, as I was telling, quite a few orthopedic surgeons, mothers have got this done, and they have lived their ends very, very happily. So T3 and T4 often in conjunction. Important thing is in primary and innocuous conditions, this may act as a primary management, but do not forget the diagnosis. Abdominal pain needs to be investigated, you find out the cause and treat the cause. That is tau 4, a very good portal for backaches. And the sacroiliac joint, hit the bone, negotiate and inject. Tau 5 are transverse process portals. And these are also called the trigger points when people are having backache with sciatica or backache without sciatica. You can hit multiple spots. Tau 5. Nowadays, I administer this. Most portal blocks now we administer with 70 micrograms ozone, 2 or 3 ml. So first we give the block, and then we remove the syringe. The same syringe will give ozone. In Sunday, I'll be giving a talk on oxidative, antioxidative processes, which you should be enjoying. And in compression fractures, lot for renal colic is a dramatic thing. You just need of analgesia comes down very dramatic. 6A and B are supra and infrascapular portals. Tau 7 is a PSIS portal. And tau 8 is a ASIS. It's a mistake, spelling mistake. It's the ASIS portal. And they are adjuvant portals for proximal femur fractures and acetabular fractures, where we can make the patient walk. Kappa, or which is the last set of portals, are around the skull. So that is K1, bindi, or middle of the forehead. And it's very, very useful in all sorts of these conditions. Tension headache, migraine, sinus headache, and undiagnosed chronic headache. That's K1. K2 is the temporal portal and is administered on either side. K3, occipital portal, just below the occiput. You can see where the injection is going. K4 is a mastoid portal. And K5 is a temporomandibular joint portal. Now these portals, and the last one, K6 is the angle of mandible, straight below the ear. So indications: tension headache, wry neck, torticollis, cervical spondylosis, cervical brachyalgia, Bell's palsy, facial twitches. Now this one is a very short video, my story. You can see my face twitching. It started twitching at about 6 a.m. in the morning until 10 a.m., 10 p.m. It was twitching very, very rapidly. Because the video is not saying, it was just flickering, flickering, flickering. I got panicked. I called my neurosurgeon friend. He said, it could be some tumor around the pituitary area. We'll have to take an MRI scan. You can see how it is flickering. Even my eye size is changed. They taken in mirror. Now, all I did was to inject myself in all kappa portals in my bedroom. Maybe because of the Zoom link, you're not able to see the twitches, but it really panicked me. And I'm mixing the halogen with water and injecting myself. That's why I injected all my kappa portals. See, unless we try on ourselves, we should not try on the patient. And there you see instantly, the whole thing became normal. Twitches disappeared. And from that day till date, I don't have any more twitches. So take home messages. Coming to the end of the talk. Number 1, sodium channel blocks are not panacea for all ills. They are basically revolutionary pain management methodologies. The treatment of the disease process is complementary to the block and is essential for management by this system of procedure. When you don't have the real diagnosis, this block is definitive. Otherwise, if the fracture, treat the fracture. If the tumor, treat the tumor. Red flags like malignancy, secondaries, or condition with surgical management is definitive. SCB works as an inexpensive pain management because the cost and toxicity is far, far lesser than a single injection of diclofenac sodium. Fractures treated by plaster also, immobilization by blocks makes the life very easy. They are non-anesthetic blocks. If there's an anesthesia with these blocks, that is taken as a side effect or wrong site or wrong concentration. Feel free to experiment from wherever the effect comes in the correct site. So what I have given you the list of portals is not chiseled in stone. We have close to 1,000 practitioners of pain portals. We do conduct an online course also. So you can message me in WhatsApp. I can send you details. And we keep inventing portals and we keep sharing our ideas. And we keep learning more each day. Avoid tight spaces like tendon, intrafacial, subperiosteal. Resistance means wrong site. And in most cases, subcutaneous injections itself work beautifully. Familiarize yourself with all portals. Keep meticulous records. Learn the procedure. Remember, patient is your best teacher. Anaphylactic reaction is very, very rare and happens with xylocaine with preservative. Methyl paraben, preservative, and xylocaine. If you use cardiac xylocard without preservatives, you do not get anaphylactic reaction. Keep adrenaline ready in the fridge. You can give it subcutaneous. Many times it's a vasovagal syncopal thing because the patient is not able to believe that the pain that was plaguing him or her for many years has suddenly disappeared. So the patient may feel vaguely hypotensive, make them lie down, raise the legs, it'll be all right. Treat blocks is a major procedure. Take all sterile precautions, wear a glove, do it in a nice setup so that you can charge nicely. Don't just keep doing it in the OP without gloves and without proper cleaning and preparation. Not all professional colleagues may be aware of this methodology. You may face or you will face opposition and ridicule. Be prepared for that. You can see how people were discussing on WhatsApp, but the guy who actually wrote this message eventually paid me and then joined my course. Armchair critics without knowing ABC blocks, without trying a single case, cry holes on social media that these videos are doctored. These are patients acting it out. This really doesn't happen. You try it and you'll know that they do happen. There's a story on a flight. One patient had a acute MI and stopped diversion flight. I just gave him a block alpha 1. His pain disappeared immediately. Anyway, after landing, he was taken to the hospital and later had a bypass. I posted this on one of the groups. And then one of our anesthetic friends started trying it out on MI patients. His ignorant colleagues were very jealous of him. And so one newspaper praised him and the other newspaper said, heart attack के मरीजों पर सीधे इस्तेमाल कर दिया अपना प्रयोग. That is, patients use as guinea pigs by an anesthetist in heart issues without referring to a cardiologist. So please be careful of your jealous colleagues. Keep meticulous records and documentation. So I will just close my talk with three small videos because I'm right in time. That's the girl, post-viral. That's the situation before, and that's the situation within 24 hours. Next one. This one is the one who was advised surgery. Massive L5-1 disc, foot drop. And you can see that he is not able to move the toe. He's moving the knee, but he's not able to move the toe. You can't hear the audio. He's able to move the other side. He's not able to move this side. And immediately after block, you can see once the shirt changes, that is his block. Now he has come back after 4 or 5 days. And now you can see that he is able to move his foot. Foot drop recovered. Remember, use the right spots for good results. And this is the last case. That's the lady. She was from Italy and she had come to Amritsar, and there she broke her trochanter. And the Italian colleague asked us in the group, and I referred her to a colleague in Amritsar. There she is, immediately after block. She's walking. And the other video, she's actually thanking me by name that she's feeling very, very happy. There you can see her after 6 days, 7 days, just carrying the walker and walking. And in as little as 30 days, she has moved to 2 sticks and then to a single stick. And there the fracture is united. You can see the dates 3rd February and 3rd March. In 30 days, the fracture is united. And there she is walking comfortably in 45 days, participating in concerts. And at 60 days, she is doing her whatever exercises she was doing. 60 days after trochanteric fracture, walking from day one, all courtesy of 100 rupees worth of xylocaine. So, I hope the concepts were not too shocking. You must try this. I will share a PDF file of my talk. I will also share a list of blocks and their indications. We have exactly 6 minutes for questions. So if you have any, I'm here to answer. Yes, please, Mike. Just raise your hand and the mic will come to you.
Thank you. I just want to know if immobilize the fracture. Is it unite?
Fracture doesn't unite by immobilization. Animals in the jungle, when they break their bones, they don't go to a bone setter, they don't go to an orthopedic surgeon, they don't get plates, they don't get plasters. They are on four-legged, they just don't use that limb. And then once the pain comes down a little, they push. Sarmiento told us that walking unites a tibia. Function unites bones. We're not carpenters to treat the bone and by just seeing the alignment. Bone is a living structure. It's like a tree or a plant. We are gardeners. So we have to tend the bone to make it unite. When you walk, when you're functional, circulation improves, the bone unites. And repeated function will realign the bones in the right position. We have to unlearn orthopedics. Current orthopedics is a trend of fixing every X-ray. It's going in the wrong direction and helps only the companies and insurance. It doesn't help the patient. The patient-friendly approach, we treat the patient, not the fracture. As Dr. Abnebner said, holistic approach, we are not focused on the disease. So when my patient comes with diabetes and a hypertension and fracture and an arthritis, it's not that I'll just treat the fracture and send him to a physician with hypertension and send him to a diabetologist for his diabetes management and say, I'll do your arthritis after I cure a fracture. Comprehensively, I manage the patient. Every problem is solved by me. As Divakar always says, that diabetes is an orthopedic problem. It is not a hormonal problem. And for that, we need a separate session and another lecture where I will teach you to unlearn, to relearn the physiology, human physiology.
I'll take just a minute
Yes?
because I am an orthopedician.
So he is
I
one of the
invented
inventors of the
modern-
blocks.
So I started first fracture was treated with clavicle fracture. It was eliminated. So I started treating clavicle fracture, but with brace, and I gave brace only 20 hours a day. So I thought that fracture will displace, but what I have found 6-7 fractures that clavicle fracture unites anatomically the total movement. My patients after clavicle fracture and brace, they ride their own motorcycle. Next day they send video that I'm working on the tractor in the farm. So I thought that it may displace, but no, doesn't. It falls back into place because the static brace loosens. They repeatedly tighten, so they have normal union. They have no pain after coming to my place. 15 minutes later, they ride their motorcycle, go back. And surprisingly, later on, I made a rule. I had 70 rules. but the rule is 56 is there. That fracture unites in half the time if linear macro motion is given. Previously, the thought was micro motion. Now, my rule is macro motion unites in half time. Clavicle fractures unite in 4 weeks. Humerus unite in 4 weeks if I allow them to work. If I don't allow them to work, they unite in 8 weeks. Trochanter fracture, if I allow them to lie down, 12
You put a trochanter fracture in traction of
and if
Siemens
you allow
Paiga,
them to walk,
patient is
4
gone.
weeks. So
Perfectly right.
the principle is totally reverse. Motion unites mood. How have you seen animals? No one has taken class to that.
See, I'd like to add one thing here. The last AO manual is 2022. And there they say that in teaching hospital, you must learn how to fix fractures by fixing undisplaced fractures. That I think is the greatest disservice to science. Why does an undisplaced fracture need fixation? When displaced fractures unite by walking. And according to the new concepts of unlearning the traditional textbooks, we have learned that 75% fractures do not need an operation. And 80 to 85% don't even need a plaster. They need to be just fully functional from day one until unite. 2 minutes more. Any other question? Yes, please. This I can close.
Doctor,
Yes.
just now you showed regarding the herpetic lesion,
Yes.
do you combine with acyclovir oral medication or just the
No, even basically initially we were giving antiretrovirals. Now we just give portal blocks and we also give subcutaneous ozone 70 micrograms. And in 24 hours, that lesion dry off. There was one question. Paramjit.
Typically, would you repeat the blocks?
That depends entirely on each block effect will last for about 5 to 7 days. And in some cases, a single block is enough, like periarthritis shoulder stiffness, disc problems, sciatica. A single block may cure the patient. But then you may tell the patient that there's an 80% chance that your problem will be over with a single block, but you may need 2 or 3 blocks. And because the blocks use relatively inexpensive and absolutely safe drugs, there's no harm in repeating as many times as you want. And again, charge well for these blocks because it has got a finance related placebo effect, which means I charge some 30,000 Indian rupees for a single block, whereas the medications and gloves and everything cost me less than 2,000 rupees. And I get patients from all over the world and happily pay the money and become ours. My colleagues were doing the same blocks for 1,000 rupees and 1,800 rupees and have a 30% failure rate, 70% success rate. Because I charge 30,000, my success rate close to 90%.
So it's a new paradigm in the sense that I'm actually understanding this. It's very coming across very new to me. So essentially, are we saying here that most fractures don't need surgery, and the reason why you do things is to get rid of their pain? Is that right?
Very correct. That's what we're saying.
Because
Most
if you
fractures
put-
don't need surgery at all.
So if you put a clavicular fracture in a brace, like in a
No,
sling,
you
that is-
clavicular
that is-
fractures, you give a block and give an intermittent brace. Divakar was giving a brace, which is removed twice for bathing. I give a brace only during daytime when he is driving a bike or going to office. In the night, I ask him to remove the brace and sleep on the bed like that. And next morning, again, he put the brace and go out. And the idea here is internal fixation benefits the companies, it benefits the insurance, it benefits the hospital and anesthetist, and benefits the surgeon. But it does not benefit the patient that much. So if I break my tibia, I will not let an orthopedic surgeon come near me. Though I have done more than 25,000 surgeries in my life, if I break my tibia personally, I'll put a cast and walk from day tomorrow. So that's the fact. As we learn, as we grow, we learn. Thank you all. Thank you very, very much. Thank you.
I'd like to call upon Dr. Benjamin to give a brief decision.
Yeah.